and then you're actually seeing people immediately and quickly. And but it was very curious that I asked people who would actually benefit from this be able to get their the low-income, uninsured, Medicaid-eligible patients, get them care. They thought more about the bureaucratic structure first, and they didn't get it. So the the ironic thing during COVID was that a lot of these organizations are very rigid in how they approach medical care. And so effectively, with COVID, they weren't treating the people who needed treatment because, well, that doesn't fit in with the NIH or CDC guidelines. And everyone knows here, the NIH and CDC guidelines are usually developed by committees over the course of years. And so they're quite often, 6 months at a minimum, if not 18 months behind what we're doing actually out, in our clinics ourselves. So they're very rigid because of all the various rules and so forth. And so someone come in, well, COVID's a virus. You can't really treat a virus. If it gets worse, go to the ER. And so they weren't doing anything. Well, there's things we can do that aren't controversial. There's a lot of controversy over ivermectin, hydroxychloroquine, and other things like that. Aside from that, there's things which we do. Now, hospital setting for severe COVID, steroids, oxygen therapy, pulmonary rehab, getting people to breathe deep and so forth, among other things. Well, why not do that in outpatient setting? Why not, budesonide inhaled or dexamethasone as a systemic steroid? Why not do that in outpatient setting? Home oxygen concentrator, tell people the breathing techniques. Why not do that at home? Mm-hmm. They won't do it because it doesn't fit in the algorithm medicine they're forced to do. So the very thing they're designed to do, they failed.
And in the end result, people aren't getting the care that they should be getting.
Increased morbidity and mortality is a nice way to say it.
Well, you were talking about Medicaid. While we're on Medicaid, and Carl, we'll get to you in a quick second here. Please don't go anywhere. Did you have the turkey sandwich? I don't know if the tryptophan did kicked in yet. I did, but either way, with regard to Medicaid and looking at the bureaucracy and the cumbersome reimbursement process, what AMEC helped, actually what we introduced through help of relationships with members of Congress, Daniel Webster down in Florida, the last Congress introduced our Pro Bono Care Act. And the Pro Bono Care Act, now we're in a new Congress, has been changed. The name, we spoke to David, and David was like, you need to rename this thing. You can't be running around calling it the Pro Bono Care Act, because when we were seeking co-sponsors, and we did generate almost 30 co-sponsors during the last Congress for this bill, some of people on certain sides of the aisle would say, well, these doctors are rich, they don't need a tax break, and blah, blah, blah. And so we just kind of scrapped the name Pro Bono Care Act and came up with the Helping Everyone Access Long-Term Health Care Act. The acronym is the Health Act. And what we wanted to do with this bill, it's identical to the Pro Bono Care Act. We want to give physicians the opportunity to treat patients, do charity care in their offices. And what the legislation was introduced in the 116th Congress, all right, and right now, we've heard from physicians that tell us that seeking out charity care is a difficult process. There's not a free clinic on every corner. You have to find these clinics. Patients have a hard time locating them. But what this bill would allow people to do would encourage more than 1.2 million physicians to take a simple tax deduction in exchange for treating a Medicaid-eligible or CHIP-eligible patient at no charge. And it's voluntary. They don't have to do it. You don't have to treat you could accept Medicare reimbursement on our Medicaid reimbursement for some patients, but not all patients. It's completely up to you. We wanted the localized care. We were thinking that, and in discussions with physicians, perhaps that Medicaid person would stay out of the emergency room for a chronic condition. And instead of going to the emergency room for strep throat, they go to the primary care physician, have a relationship established with that person, and maybe they'd have better health care outcomes. So the idea here was to break the cycle of the patients going to the emergency room for primary care. And we ran some numbers, and we looked at reimbursement rates, we looked at CMS numbers, we looked at HHS numbers, Medicare and Medicaid numbers. And this is what we discovered, and this is what got us excited. And when we were presenting this bill on Capitol Hill, some offices were saying, thank you for coming here with numbers instead of just ideas. In 2015, 19.9 million of the 73.6 million people who were enrolled in Medicaid visited an emergency department. Medicaid paid on average $1,016 per emergency department visit, or $20.3 billion. Now, if just 7 million of those 19.9 million people visiting the emergency department went instead to a primary care physician, we're assuming this was not an emergent situation, but a chronic condition. They went to a primary care physician at the mean Medicaid charge of $160 for a 45-minute visit, and that physician was able to take a 32% tax deduction, which is the highest allowable under the tax law. That $1,016 that Medicaid paid for the emergency department visit turns into a $50 tax deduction. All right, and again, this is completely voluntary. The tax deduction for seeing these 7 million patients in a primary care setting instead of the emergency department reduces the Medicaid payout by approximately $6.6 billion. When we were on Capitol Hill talking about this, people would lean forward and say, well, that's pretty significant. All right, now we realize these numbers could fluctuate depending on, on what service was provided, but we're in the billions of dollars ballpark. And all we wanted to do with this bill was to give physicians the opportunity to treat, to do charity care without leaving their office. Now, right now, they can drive to the free clinic, they can write off their expenses for getting there, but they cannot take a tax deduction for professional services. And we wanted to do this to give physicians the opportunity to treat these patients, establish a relationship for the Medicaid individual and their families to come into the primary care setting, and we think that it would deliver better health care outcomes. So that's the Health Act. We expect to get this bill introduced. Right now it's in Legislative Council, and we expect to get the bill introduced by the end of this year. So I don't know what. Did you want to comment on that, Dr. Porter?
Well, yeah, it's how many people here, when I have a less medically heavy audience, a lot of people will say, yeah, when I sprained an ankle, I have strep throat, I can't go see my primary care doc because it's going to be at least a couple days, if not weeks, to get in. And then, and that's particularly true for the FQHCs, really 3 months. And they said, our data says only it's a month and a half. Yeah, they just cooked the books just like the VA did. And it's going to be 3 to 4 months sometimes to get in for a strep throat. You end up going to urgent care. And if you go to one of the urgent cares run by the FQHCs, this is the ones I used to run, with the volume they had, you couldn't get in. You'd actually go to the ER department, and then that hospital would actually bill the county for it. So you just see how the money's building up in one way or the other. I don't say I'm a direct primary care. I say I'm direct primary care and urgent care. So I want people to know, because I block on my schedule every day urgent care appointments so people can come in right away. And sometimes it's just a simple telemed. I sprained my ankle, so I'll put an order in at a local place where I can get their ankle x-rayed, and then I can pull that up on my computer without the person coming to see me. And so you can get everything done that way, and it's not an urgent care visit, because family medicine is board certified. But that because of the way the insurance system is developed, Medicare, Medicaid, all these things, CMS is quite the pyramid. As things trickle down in bad ways. People now think urgent care is a different specialty than primary care, and they're not going to go see their internal med or family medicine for that very reason. So when I put those two together, people say, oh, I can come to you? You'll actually be able to see me in a close time for strep throat? They're stunned. So, yeah, you can do it very quickly. So, and a lot of people, 80% of ER visits are actually urgent care visits. But you don't know if you're a layman. And so I had a guy who basically had an allergy problem with his ear effusion just all swollen. He didn't know what he had. He thought he had a neck tumor. Well, he needed some Zyrtec, but he didn't know that's a part of it. So, and he had no insurance. So, $5 for a bottle of Zyrtec instead of a $1,500 bill at an ER. That $1,500 might be generous. Right. So little things like this. That's where that's a practical example of exactly what you're leading to.
Right. With regard, now, I have to be certain, or I'd have to assume that you're allowed to dispense pharmaceuticals and prescription drugs from your Texas allows you to do that, or
it's limited in Texas. Okay. Something that we're working on, and there's a lot of restrictions against it. So I can do immediate needs. So I have a variety of medications I give out in the clinic itself, but I can't give prescriptions, dispense it for long term. That means I'm acting like a pharmacy. Otherwise, I could do metformin, common diabetic drug, for $1 a month.
That's what I wanted you to get to, like the huge savings associated with. In some states, I know Dr. Kim Korba, and the savings that she talks about in her DPC practice from dispensing prescription drugs is astounding.
And in fact, and this is again, it applies to Medicare, and so Texas is one of the laws that's, there's a couple reasons why that's been opposed. It's all politics and the kabuki dance that goes around in various legislatures. So we're working on that actively here, and it's a multi-year process. But in Florida, that example where they have excellent direct dispensing, and I was listening to this lecture when I was discussion as I was thinking about opening my own DPC. With direct dispense, Medicare patients, they would actually save more money on the co-pays by getting the direct dispense for the common blood pressure medicines, cholesterol, and diabetes, things like that. The wholesale cost for those drugs, combined with the membership, was less than the co-pays they pay through Medicare.
Mm-hmm. Okay. All right, I want to get to Carl, and then we can circle back. I'm sorry for that administration. You guys can, that administration reference there, I don't know where that came from, but I apologize. We can come back and talk about solutions that you wanted to discuss, but Carl does a lot of work in the community, and the community can provide a very viable safety net for the most vulnerable, and he's got some great examples of how he did just that with the organization that he's with. So, Carl,
am I allowed to speak?
You are allowed to speak,
Okay,
sir.
no. That's the longest I've ever gone quiet in my life. I'm competing with Dr. Mass on that. But first I want to thank David and everybody for having us here. And also, last time I never met Andy before until I guess last night. No, last time I talked to Andy, I was in a deer stand doing a telecast for Free to Care when it was virtual in 19. So the only thing I didn't do was fire my gun because there were no deer around because I was yapping for about 10 minutes in 35-degree weather.
I didn't recognize Carl because he's not wearing camo.
That's right. And then next thing, somebody says, "Are you wearing pink pants today?" And I said, "Well, it's the fall, so we don't wear pink in the fall." So I mean, that's the next. So maybe I should try that pink she camo stuff. That might work. But anyway, no, I appreciate that, and I want to thank Dr. Woosmith and really Dr. Mass for introducing us to her and that whole Physician Outlook magazine. Is this too loud? I need to move it back. Oh, no. You need to really take some time and read that magazine because we were honored, and again, Dr. Mass came to a big conference we had down at arguably one of the most beautiful places on earth. I'll let her argue or disagree. She's not going to say anything? But y'all really need to learn what we do, and that's where the big disconnect is. I mean, that's where y'all heard me. I get pretty frustrated. Everyone talks about the problems. That's all anyone talks about. So I hope I can share a solution or two, and you won't find a bigger fan of you, the physicians, than myself. I mean, I grew up the son of a private practicing OB-GYN who was in private practice for 48 years. And so I kind of got to see things as it evolved to where it is. So we have a different view of the world than I think most people that y'all think that supposedly, I don't know, dress nice and slog insurance around. That's not what we do. It's a very big difference of what we do. But anyway, what was your question?
We're talking about how the community can provide the safety net, can participate in constructing the safety net for the most vulnerable.
What we have to do is we have to get care back to a local level. Healthcare is not national. It ain't regional. It's local. And you've got to relocalize it. And what he's referencing, you want me to talk about the hospital? Or
Please.
Okay. So we worked with a hospital in the fourth poorest county in the state of Florida. It's called DeSoto County. Per capita income, $25,406. It's predominantly a big, heavy agricultural area. Down there, a lot of immigrant workers. About 35,000 people in the county. And the hospital's a 49-bed hospital. And anyone that follows this rural health care knows, especially in Texas, of course, Texas is the biggest state in the history of the world, right? At least that's what I'm gathered from everybody. And they've had a lot of rural hospital failures. Georgia's had 8. I know y'all probably thought I was from New York, but I'm not. I'm from Georgia, Middle Georgia to be exact. But, it's a real problem. So this was a hospital down there that was at the time a dish hospital. Does anybody know what a dish hospital is? Good, so I'm impressing you with my vernacular. Okay, thank you, Dr. Dewey. It's disproportionate share. They treat enough Medicaid patients. They get a different status and get reimbursements from the government. They can also do, and I don't want to go down this road, and I know Bill Miller's gone, 340B. They have access to 340B drugs to be able to do that. Well, what happened in that hospital in 2018 is they lost obstetrics. So you have to drive an hour to have a baby if you live in that town, and the town's Arcadia. And that's a big problem. I mean, what are women, what are families going to do with not being able to have a baby there with this hospital? So once they lost that status over the course of time last year, they lost their DISH status because a lot of the deliveries were Medicaid based. So they lost their DISH status. So it's been tough. And then in these hospitals right now, and y'all know with COVID, they're having to shut the OR down for periods of time to pull enough nurses over to help with the rest of the hospital. So it's been it's amazing. But what they did do is when we met them, and I want to make sure I give the credit to all you docs who are on your telephones out there typing emails. You might want to listen to this. Dr. Lee Gross is who brought us to the hospital. So a physician brought us to the hospital. And that's really what needs to happen. And he had heard about our fair cost health plan and what we had built. He brought us to the hospital. It took a while, but we finally got hired. And we got hired, I think, in August of 18. And we proceeded. We sat down. I'm going way too long.
No,
of course, I had to sit there for 20 minutes with y'all. So
Anyway. We'll sit here and be quiet.
But this is important. I got to get to a point quick. We sat down on October the 1st, 2018, from 1 in the afternoon to 6 at night, building the DeSoto Memorial Health Plan. So it's a DeSoto Memorial Health Plan. They used to be with, and I can say this, is this being recorded? Okay, it is? Okay, that's fine. Well, I don't, this is small enough quarters, I can say them. They were with UMR, which is owned by United Healthcare. For those of you that don't know, United Healthcare only owns 636 companies. Pretty small, number 6 in the Fortune 500. But anyway, cartel. But they were with United. They had Optum PBM, another winner. And when we got involved with them, we sat down for that 5-hour meeting and built their plan from the ground up. Dr. Gross was present at that meeting. And I'll never forget the day when I said, you know, Dr. Gross, you're going to have to file $0 claims. Dr. Porter, you're going to have to file $0 claims. And he's like, you could have driven a Mack truck in his mouth. I mean, he's just sitting there. And I said, well, how are we going to know what's going on with the encounters at your office? So he agreed through the EMR and so forth. We were able to do it, pretty good integration. And so therefore, all the claims we get, again, there's no cost to the claims, right? Because it's DPC. The hospital pays the per employee per month fee to the DPC to Dr. Gross's office. So we did that. We had our cost and quality navigation company with us. We had our TPA with us. We had our network development partners with us. And we had our stop-loss carrier with us. And as we built this plan, we had another hour or two meeting thereafter, but we built it. In the first year, they saved $1.2 million or 54%. David wouldn't let us show the video. We had plenty of time to show videos, but he wouldn't let us. But we did it. We did it at the Texas Public Policy in 2020. We shared it in the front of that talk with, I guess it was Jamie Lagarde and Senator Colkhurst. So anyway, long story short, that we were able to save them that much money. The significance of that, guys, was they had been working and they've been what's called self-funded, and I know that's a term. We were talking with Taylor Rogers over here earlier today. They were partially self-funded with UMR for, I don't know, over 15 years. So in that first year, they saved all that money. And I'm going to say this, do I think we're great? Yeah, sure, we're great. I mean, I'd be crazy not to tell you that, right? But it was Dr. Porter, it was Dr. Gross that really made the difference for that plan. And then all the cost containment, solutions we have in our fair cost plan, but it started with these guys. And that's when it was front and center. I've had benefit advisors not understand DPC, and boy, I'm not a bigger proponent of it than I am. And over the course of time, that first year with all the money saved, they hired their first full-time surgeon in county history. So you're talking about really making a difference. And you've got employees, you got people that don't have money, and what y'all get to see the other side of things. We try to design plans so we break all barriers to care, remove them all. So these employees, if they go inside the hospital, they have no deductible, they have no copays. And you can see the video of this, and they saved all that money. And how do y'all think we saved all that money in 1 year? Anybody? We eliminated the middle. I just said we got rid of United and Optum. Wow. I mean, that just shows you how much fast there. Imagine, and by the way, it's only 157 employees. Imagine if there were 1,000 employees. So those are the kind of things that are possible, but we know how to integrate you into the programs and treat you. And I learned this from my father. I mean, how many of y'all have to do pre-certs and things like that? We can customize plans to remove pre-certs for certain procedures. That's the kind of thing that we do. But the reason you guys and y'all, everyone's done a great job of explaining the problems, which, again, we've been talking about for 10 years, but it's great to hear it again. You've got to somehow get in these health plans, and it has to be done at the grassroots level. And if we build them right, you can be paid well. We pay our doctors, and there's no reimbursements, by the way. Get that out of the vocabulary. How can you get reimbursed for a service you perform? You know, you're being paid for your service. So we want to pay the physicians much more than the bucas, because y'all are the most important part of the whole plan.
You have to explain the BUFUs. Please define that acronym for our audience.
I don't know. What did he just say? Did y'all hear what he said? That reminds me of Dr. Mass last night.
Okay.
BUCA, Blue Cross,
BUCA.
United, Cigna, Aetna, Humana. Everybody got that? Was that too fast for a Georgia boy?
One more time, please.
Blue Cross, United, Cigna, Aetna, Humana.
BUCA.
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 It's much easier to say if you live in Florida, Cuba. But anyway, it's much easier to say than pronouncing their names every time. So
I'm just saying you eliminated that.
yes, we got everybody goes, what's the secret? We just eliminate the middle. And then the employees have got good care. The doctors aren't dealing with all this red tape. They can treat the patients. And our team, the way it works together, that doctor is the front and center piece in that patient-doctor relationship. And our model allows that to happen without all the interference from these counterproductive barriers that's frustrated all y'all for years. And that's what I'm saying. To get y'all where you want to go, you got to get with a good benefit advisor. And we got 31 offices across the country, and I know plenty more. And work with them and go in your communities. Dr. Gross brought us to the hospital. I mean, look, I like Arcadia a lot, but it was not on my radar. I mean, it's South Central Florida, and there's nothing, no redeeming quality. It's not on the water. It's hot as hell. So anyway, I'll shut up.
Well, one thing, a story that Carl was relating, we were chatting about last night, is Dr. Gross, one of the other people was at DeSoto Hospital who had met Dr. Gross years before as his primary care doctor. Says, that's the guy I just went to, the primary care doctor, and 5 minutes, he gave me a pill, a referral, and moved on. That guy wasn't a doctor. He was just moving stuff. So the guy was surprised when Dr. Gross had now become a direct primary care that he was actually spending all this time. It wasn't Dr. Gross being allowed.
That was the other client.
Well,
the CFO at the hotel where Dr. Mass was.
Yeah.
Go ahead, you tell.
Well, it shows the structure of the problem is that if Dr. Gross wasn't a bad doctor, the system that was created to do all the charting and all the rest of it had put him in a bad situation, which we all talk about. We killed that horse, but he found a solution. So Dr. Gross and Carl got actual solutions, drop care, and significantly better care. And then that's one of the biggest things.
The care of these people, I mean, you should see, her name is Hanna-Barbera Johnson, and I'll show my age. I'm like, Hanna-Barbera, is that the cartoon company, But that's her name. There's no relation, I'm fairly certain. But she did a 1:30 video, and I'm glad to send all y'all, or David can send it out. But what she said was so powerful because, what y'all are, the patients you're treating here are functionally uninsured. I mean, the only strategy these dumb brokers have done, and I'm not a broker, don't call me a broker, I'll be out there whipping some tail in a minute. We're benefit advisors, a big difference. We're not really selling anything, we build health plans. And, but anyways, the plans that are out there being sold are high deductibles, high out of pockets, and I don't want to set off a firestorm about HSAs with you guys, but I'm here to tell you, when you put those in, the employees don't go get care. They're scared to death. They don't take their meds. That's what happens. So we need to break those barriers. So y'all are dealing with a functionally uninsured population, and when these people go to the hospital with a $7,000 deductible, they've blown through it. They're never going to pay the hospitals. We know this because we work with hospitals. We work with large hospital systems working on direct contracts with our clients. We were out there with Taylor and Rich yesterday at a big hospital here in Austin. talking to them about this model. How about a hospital not having to go collect out-of-pockets and deductibles from members? That member goes there for free, the patient does. So then you can work a good deal with the hospital. So that's what we try to do. But again, we want the doctors to be able to practice medicine, like my dad said, and take care of people is what y'all were trained to do. But this other side that we live on, you need to really understand this side because it will enable you to be more financially successful, and it'll be able to let you give the care to the patients without all the hassles. And imperfect, but it's pretty darn good.
Right, and I'm sorry, go ahead, Doctor.
Well, I was just saying my first year, I had one medical assistant phlebotomist that worked for me. I had no billing department.
Yeah. There are, I'm sorry, did you have a question? Okay, there are, the example is there are employers in communities throughout the country where you're building an employer-based plan instead of an insurance-based plan.
Employer-built healthcare,
yes.
Not insurer-built healthcare. Insurer-built healthcare benefits Wall Street, not Main Street. And you got to get the money off Wall Street, back to Main Street, and build plans that work with the community. I can get into that later, Andy, if you want me to, or talk about a community health plan and what that is. I don't know if you want me to do that now.
Sure.
Or not. Yeah, go ahead, Dr. Mass. We are. Should say more.
Well, I know there's going to be obstructors that are in there in the community preventing you from doing it. Is it just self-doubt coming from the employers not believing you? What is it that's preventing more places from knowing about this? And I'm asking the question because I've tried with my school district.
Well, that's another story. I mean, with that and the politics, and you got COVID and everything else up there. But right, I will say this. So COVID, we were ready to go talk with the city. I'm going back to Arcadia, the city of Arcadia, the county, and the school district. Those are the three biggest employers in this small town. And we were going to go talk to them about this. And the funny part was we had a meeting with the county the day Patient Rights Advocate, and I can't do this without giving them a shout out, Cynthia Fisher, Larry Santangelo, Linda Bent, and that team and what they did. If y'all know who Patient Rights Advocate is? I mean, they heard about what we were doing in Florida thanks to Marnie Jameson Carey, another friend of you doctors, Association of Independent Doctors. Marnie said, hey, you need to come meet Carl, talk to their clients. They came down and filmed them. The day they filmed the videos we were talking about at DeSoto Memorial Hospital, we met with the county, and we'd already saved all this money, and we still hadn't got the county as a client, to your point. So it's extremely, when you get with these municipalities, it's extremely political. COVID derailed us. We totally lost 2020. There's nothing we could do then, and that they were all dealing with that. We were down there in July, Dr. Mass, met with the city, the county, and the school. And the county said, you've got to get this past the constitutions. Hey, how you doing? You got to, that's what I was supposed to do, right? I've never been doing, I'm nervous. I've never done this before. But anyway, we met with the county, and Dr. Mass, you'll love this comment. So her name is Mandy. She's a sweetheart. She said, I said, Mandy, she's going, Carl and Barry, my co-founder, Mitigate Partners with me, was with me. Why aren't more companies doing these programs y'all are doing? Why are we not hearing about it everywhere? And I said, well, you got to have a good advisor first off, because most of the brokers make a lot more money the more BUCA plans they sell, and they get bonuses, so they're not interested in changing. And the big name brokers that are all publicly traded, they're upholding their fiduciary responsibility. So you really can't get mad at them. They're delivering great stock value to the stockholders. That's their goal. Unfortunately, there's an employer on the other side of that fence that's getting, screwed pretty good. So what we did is I told her, I said, Mandy, I said, the question you ought to ask is, why isn't your broker talking about this stuff? And she goes, well, Carl, he's a part of the cartel, because he had talked to me before, and I'm going, were you kidding me? But she's got to go to the constitutionals and all the people that are involved, and it's a process. So that's the struggle you have, but if you can bring the city, the county, the school together, and we built at DeSoto, and we're in the process now again, but this variant, COVID deal, that's what you have to do, and you get everybody working together, and you're back to Marcus Welby MD days. You're back to neighborhood health care. neighbors taking care of neighbors, and letting the doctors, the hospitals, don't forget the community pharmacist, the pharmacist, and everyone working together for the patient without all the hassles. So that's what we're trying to do. That's what a community health plan is. I think doing something in Austin, Texas, it's a pretty large city. The things like that are more challenging, I think. But you do have a lot of hospital competition, which is good. But I think the other thing you got to do, if you guys all have patients that are in the C-suite of the company, talk to me, call us, get them on the phone. Let's talk to them, because the employers need to go to the hospitals and say, what are you going to do for us? See, they've never had that before. Well, we negotiate with insurance companies. Well, they kind of suck at it. That's why we're here. 50% off something that costs 20 cents that they bill out $1 million doesn't do me any good. Who cares about a discount? So we need to have that discussion, and the employers need to bond together in these communities, and they need to be the ones leading the charge. And especially if you have hospital competition, what are you going to do for us? That's what CalPERS did, California Public Employees Retirement System. Look it up. 2011, they were getting killed with hip and knee replacements, all kinds of charges, $100,000, $20,000, whatever. And they went out and picked 49 hospitals and said, we're going to pay you $30,000 for every hip and knee. CalPERS is like the largest health plan in America, 1.3 million lives. Okay? 49 hospitals agreed to the price. Over the course of the year, every hospital lowered their price to meet, so they could all, because they were losing so much business. And we did that down at Orlando. I'm not involved anymore with the school district down there, but we did that with the school district. We had one hospital, and I don't know if I'm on, it's very much, shockingly a nonprofit. No, y'all have never heard of those kinds of hospitals, but in a very religious affiliated hospital group. We had 65% of the facility claims running through this one hospital. They didn't really want to play ball, so we went over here and spent 3 hours, and I had Dr. Mass with me, and we wore them down together, and they finally agreed to some good pricing with us. And they're our partner now in the anchor hospital in this school district. Within 6 months, 65% of the business, this is a 9,100 belly button group. It's a big school district. 65% of that traffic going over here dropped all the way to 7%, and 73% is going to the new hospital. And that's amazing. How about some applause? I mean, no, but I'm saying that's what's possible. We shifted the entire dynamics of that group, and the members got to go to that other hospital at no cost, and the quality was better too. So anyway.
You talk about neighbors taking care of neighbors. All right. University of Houston is opening a DPC clinic on the campus of Memorial Southwest Hospital, and the clinic is aimed at low-income Houston residents, Medicaid beneficiaries, and it's the first foray for DPC into the public sector healthcare. And David sent this to me, and it's fascinating. Could the VA be next? Who knows? But this is a great, I don't know if you'd call it a beta test, because it is the University of Houston. But Dr. Porter, it sounds like they're doing what you're doing, only on a larger scale.
It's actually very optimistic. Now, what we do is, old school medicine, like to tell people, although I promise I've read a book recently. It's not that old school. But that old school concept, patient-physician relationship that David, quite often talks about, getting back to that, is really what it is. Now, what they're going to do at the University of Houston Medical School is actually have residents involved, and that'll be part of their training, and then they've gotten all this administrative out of it so you can get back to better medical care. Now part of it is, when you try something new, what works and what doesn't work, how much administrative oversight will there be? I've had a lot of people offer, hey, I'm going to bring you patients as long as you sign this agreement. We'll bring you patients, you give us a cut, and we'll just occasionally inspect you. Like, out, 86 of those guys. Too much organization causes these efforts to fail. When they try and people come in, bureaucrats trying to overmanagement, let the doctors do what they want. And one of the most important thing I'm seeing is patients really want this. They really want better care. They know they're getting sucky care. That's a technical medical term, sucky. But they know it and they want it, so they're reaching out. They're looking for that better quality of all age groups, all different social economic groups throughout the world. When I've met a lot of different people in the low-income, uninsured, immigrant, non-documented, documented population, a variety of different categories. They all want the same thing, you know, and they want that proper care in a reasonable time frame. They know they can't answer the phone all the time, but they all want that. If the University of Houston lets that do this, they're going to teach a new generation of physicians really, you know, how to do it right in a very important way. Now, another example of this, which is very encouraging, there's a group out of San Jose that's a physician. She did some missionary work. Her husband's an engineer, and they just came up with their own concierge practice. Direct primary care. Concierge is a little different than direct primary care because quite often concierge is membership, but they also bill insurance. What they did was more maybe boutique, but a little higher end direct primary care cost. And they tell the people who sign up as members, we're going to use the extra money to actually fund a DPC, a nonprofit one for low-income people. So here's innovation, finding a better way to get stuff done. So that's in San Jose. I saw an interview. Some of you guys know Z-Dog MD, Zubin Damanian. He did an interview with those people. It was very interesting. It's something we can do here. So University of Houston's doing it. These are innovations that actually get care where it's really needed. So it's a really positive way to do it. Now, it's very interesting. A lot of people want to push Medicaid expansion, and that's a very political term. And you know, Medicaid system doesn't work very well. We all want to get better medical care to people who can't afford it. But using a system that's not working very well, let's find ways to make it work. Opposition, and I don't say it political, but quite often it's more bureaucratic. If you actually remove part of the bureaucracy to make things better, now someone has to get another job. I'm okay with bureaucrats having to get another job. Sorry.
A lot of people are hiring right now. Okay. And I think, Carl, you know, with the DeSoto case study that you just explained, when we were on Capitol Hill, when we are on Capitol Hill talking about our Health Act, talking about the Pro Bono Physician Care Act, we cite statistics that we're losing rural hospitals at an alarming rate. And one of the reasons that we're trying to get, you know, co-sponsors for our, you know, our proposal is that how many primary care offices does that Medicaid beneficiary or the CHIP eligible patient pass up on the way to the emergency room to get care, but in the rural area, the hospital's gone. The importance of what you did underscores the importance of maintaining and sustaining these rural hospitals as a source for treating the indigent.
And no, and I want to make sure I give credit to Vince Seco, the CEO, Lois Hilton, Director of HR, Dan Hogan, CFO, Teresa Connolly at the time was the controller. I mean, they're the courageous employer that made this possible. And we have to help the employers become courageous and not have a risk to take when they do this. So they deserve the credit, and Dr. Gross deserves the credit on all of this. But what I will say is, I forgot what's your question.
Talk about sustaining rural hospitals.
Dr. Gross set up several kind of medical tourism events. And there's also, y'all know Dr. Rebecca Barnard, excuse me, trying to do something with her down in that region where she is. I was working with another hotel company. She also sent a patient up there. And what Dr. Gross did for, I believe the cost was $17,840, I think it was what it was. I'm pretty... 20 cents? No. Oh, that's supposed to be funny. Apparently not. Anyway, I'm not funny anymore, I suppose. Maybe I should have worn pink pants. But anyway, they were able to do that and brought a surgeon in from Sarasota, Florida, for this particular procedure. So, and it's a 4-star CMS hospital. So there are only 19 4-star CMS hospitals in Florida. It's a good hospital. Just doesn't do cardiac, doesn't do OB, it doesn't do everything. So we have had some DPC docs, you know Rebecca, don't you? You know she is. You know, send patients up there to have procedures done, and they have tremendous outcomes. That's another thing when you talk about safety nets. I will tell you, when you look at some of these hospitals and if they're a 1-star rated by CMS, that's a tough sell. And when you find that community with that 1-star rated hospital, you know, my great-granddaddy died there, you know. I forget I was getting a haircut in Madison, Georgia when I was working with this doctor years ago. And it's a little dinky hospital in Madison, Georgia. If y'all don't know where that is, it's the only town that Sherman didn't burn on his march to the sea in the Civil War. It's one he skipped. But anyway, I used to drive through there going to Athens, to the University of the South. The Harvard of the South, my bad, University of Georgia. But, University of South Sewanee. Anyway, I had too much to drink last night. No, I really didn't drink anything. But that doctor, I remember getting a haircut, and I was asking about the hospital, and the barber goes, "Oh, no way, I'm ever going there. My great grandmother died there." So when you deal with these 1-star hospitals, you have to target, I think, the 3 to 5-star hospitals if you can find them, and focus on those. And we talked to the Florida Rural Hospital Association back in August of last year, and unfortunately, it was virtual. So the only people on the thing were a bunch of people like myself wanting to hear how we did it, not the hospitals. But you've got to target those really solid, I say good rated hospitals, and work with those first. And that should be the first target. And then get them to build their plan right and take their employer-built plan out to the community and build the same one for the rest of the community.
Yes, Rebecca.
Thank you. I have a question. As an employer, I always look for ways to bring more, better healthcare to our employees. Very important to me. My father was a tremendous supporter of DPC. He loved the model. And interestingly, my mother was always afraid that what could happen if there was a disease that now, cancer, something like that went into the millions of dollars, the out-of-pocket costs. Do you find that the DPC model is rejected by some because of the potential huge costs that one could incur? And is that the same issue that you're facing with employers who may be not willing to push a program? I hate to call it a program. This is so innovative and it's wonderful. I love it. But how are you dealing with, how are people protected in the event that they have, major exorbitant?
Yeah, I'll just say one quick thing that I'll give to Carl, is I get that question quite a bit because a lot of people present, now brokers sow fear. That's how they profit, right? They want to use that. Well, if you go there, you're just not going to get your leukemia treated, whatever. And that's just, it's nonsense. It's just I'm primary care, urgent care like anyone else. If someone gets to a certain point, what do? I refer it, just like any other doctor will do. Now, unlike most primary care in the insurance system, if someone comes in and says their heart rate's racing, ooh, that's the heart. Refer to cardiology. Next patient. Time for a Z-Pack, right? No, I'll actually work it up. So I got an EKG. It cost me 2 cents of paper and a few electrons. I can do all that stuff early. We actually get better care that way. But the fear is there that people will get that $1 million catastrophe. So that's where we have to present and say, look, I'm getting your primary care and your urgent care. I'm doing 80, 90%. That other stuff, I know a guy. He needs cowboy boots, but that's another story.
I got them, but it's still hot outside. I don't wear those.
Just got to know how to wear them.
You want me to? Yeah.
Again, something like my mother says, well, what if my bills are in the hundreds and hundreds of thousands?
Yeah.
In other words, who's the guy?
Sure.
Right.
Yeah. Let me. Are you an employer?
Yes, employer as
Why
well.
hadn't you called us? What's going on?
Well, we are.
We listen. We'll be. Well, Andy, why were they not talking? Listen.
Yes.
If you can take some time after it's over, we'll be glad to speak to you.
I would
Our
love
fees, $100,000 just to speak, but we'll give you the PPO discount today, and we'll do it for free. Okay.
I think he.
But no. All seriousness. The way we build these plans, I want you to think about a house as a health plan. We build it brick by brick, and each brick represents a cost containment, risk mitigation solution, and we have about 20 of those in our plan. You won't get that in an insurer-built plan because they want the cost to go up. That's right. No, they're not on your same side of the fence. So we have an oncology component. Unfortunately, the person shut the company down. It was unbelievable, and we're trying to find another good one for that. But we try to do a lot of that work up front, so a lot of the negotiations and the things are done. We do a lot of cash are done up front with that, especially when you get the chemo and radiation. We try to do that stuff up front. So the member, if they follow the protocol in our plans, they're not going to have any cost on their end. The employer will pay for it. But we protect the employer because we design the plan right. So you're not going to get some insane bill of $400,000 and some garbage discount. Okay, so that's how we do that. So they're taking care. This is about the members, the patients, if you want to call them the employees, and the doctors, and letting the people that are supposed to take care of people take care of them. And I tell you one last thing: if you want to pay less for health care, you got to pay less for health care. It's not complicated. It's not.
So you get all the stuff paid for. Everything that's done before for any other insurance or the BUCA plans, you get better primary care, you get hospital care, better referrals. Everything that you get from these other ones that they promise, he actually accomplishes.
I can give you a million stories if you want to. Yeah, there's a lot of people. Taylor, you want to ask questions? Taylor, you have a question?
We got a question right
Oh,
here
I'm
first.
sorry, my
It's
bad.
okay.
Just trying to
I'm
take care of
sorry.
my boy over there.
We'll get to him.
Well, the ACA, caps out-of-pocket expenses. That's a law, part of the Affordable Care Act. Yeah, I believe it's at 17,000 out-of-pocket expenses annually this year. So that's part of the law. So just to answer your question, if you're going to have $100,000 worth of expenses, the law actually protects you against out-of-pocket expenses. But my question is, seriously, medical economics is the way we've always managed our practices over the years. You balance it out. You always took care of your insurance patients, subsidized your poor patients. That's just how it balances out, right? So that you don't have to bill, and if you have a patient that can't afford it or is a Medicaid product or is undocumented. The undocumenteds are really a tough one, right? Because the world is now all fully insured, but what happens to the undocumented? In my community, I work very closely with a federally funded health center. We used to have free clinics there. My husband did the surgical clinic, I did the free breast clinic. Then we said free couldn't be done anymore. The health center told us to go away. And we work with family practice residents in a top-rated program. And it was ridiculous, and I just didn't understand it, but now I kind of understand it. Because there's a bureaucracy set up in these federally funded health centers that they're now drowning under with the ACO models. And it's funny because one of our founding advisors for UberDoc is actually now the CEO of our ACO, and she's a managed care expert, and was the one who kind of taught us how these processes are not always what they seem. So I completely understand. So there's a couple in New Jersey, husband and wife family practitioner, that moved across the street from their federally funded health center and opened up a clinic that was direct pay. And they figured it was $15 a patient. Okay, $15 a patient. They could get donations from everywhere. They have surgeons donating their time, and they are able to negotiate with hospitals for rates when patients need something. And it's just pure medicine. You just keep records on your patients. You don't have to fill in all the paperwork. And again, these accountable care organizations are just literally putting they can't afford it. So I completely understand it. Many people are not aware of these health centers and how bureaucratic they are. So I went to my federally funded health center because we got a very good contract. We got a great contract with the state of Massachusetts for physical exams. I mean, literally they said, hey, this is easy. We don't have to make a phone call. You push a button. We're just going to give you cash and give it to the doctor. Fabulous, right? I went to my health center and I said, look, this is going to be a few $1 million top line revenue into your health center, right? Into your health center, and you can have mid-levels, residents. It's wonderful. How not to perfectly take money that the state, give it back to where it's needed. And I went twice to that. And the answer was, well, things are really complicated. We have COVID, we have access, we're trying to figure this out. They turned down about $4 million of easy access money. And I was astounded. And when I did a little more digging, I realized that there's so much bureaucracy. There's so many people, and at the end of the day, they're working in that system, and it's like. So I went to another health center in another poor community, and they're really interested. But I feel badly because it's the community I work in, and I take care of those patients, and it would just be money going, like Carl said, back into the community. So I kind of think that people have to be aware of what you pointed out, which is not what people don't understand. And part of the reason, and my mission is to get every doctor to open up a direct pay seat, not to be concierge, not to charge more, but to give a fair price and better access.
Right. It doesn't have to be membership, right? Yeah, you can do different things with it.
It's fair price, direct access, give the power of the dollar to the patient. I would even say help vouchers. Give poor people federally funded health savings accounts. Let them find what's best for their child.
Yeah.
Why wouldn't we do that?
Here, here.
Or balance even.
I think there's a whole.
Anywhere.
The-
So I just think that there's a bad rep when it comes to concierge and DPC, and that's part of
Yeah, I was an insurance lobbyist a couple months ago, a year ago. Time flies from the sessions.
I'm sorry.
It was basically was trying to throw DPC under the bush, under the bus, call it boutique medicine, a variety of things. They're trying to protect their turf, and you understand someone trying to do that. But on the aspect of why someone's resistant in a bureaucracy to a new idea, you could do have a PhD in organizational psychology. Part of that's just, well, that's not my idea. How will that affect my turf? As a friend of mine said, he's a civil servant, and I'd worked for the government at one point, and he said, yeah, my number one job is to keep my job. And there's that type of bureaucratic resistance, organizational resistance, and then finding ways around it. Eventually find the right people. You find people, I'm going to innovate it, and those other people, when they realize they've been left behind, they adjust. Those types of market forces isn't the right phrase, but when people have choices and options, they go around them and put those guys out.
Did you have a question?
Yeah, I just wondered, Carl, could you comment on when you were talking about the hospital and what services they don't? You said they didn't do ortho or they don't do cardiovascular. So in that health plan, what happens to people who need one of those services?
That's a good question. They do some ortho. I was in there, but the cardiac and obstetrics. We were able to do what we call, I'm getting the weeds over here a little bit, but we have more of a 3-tier plan. So if they go inside their own hospital, here's what the cost is, nothing. Then we have a friends and family group, and so we have a hospital that we've been able to work with that agreed to some fair pricing. That's one of the best hospitals in Florida. And I think it helped having the hospital to a hospital, kind of conversation. And so we did that. So that's where we have the deliveries and some of the other major procedures.
Yeah, I was going to follow up on the question about complex diagnoses and high-cost claimants. As that goes, one of the things we get. Thanks. There's a healthcare provider here that's got a heck of a marketing engine down in Houston that would make you think they're the only people in the country that can treat cancer. They're really, really expensive. You probably know who I'm talking about. When you have a patient who just has to go there or has a diagnosis that requires them going there, how does your plan make sure that they get access to care and that it's covered and the employer's not the one footing the $500,000 bill? That's for Carl.
Nice try, Carl.
Can you repeat that? In all honesty, Taylor, so far, we haven't had, that's hard to believe, we haven't had anybody go to MD Anderson. So, well, I know, but I think we know who you were talking about. So I'm sorry I let the cat out of the bag. Nobody else knew that, right? We just hadn't had anybody go to it, but if we do, then the only thing we can try to do is to protect the member and do everything possible, but so far we haven't had that. And what I'm finding, see, again, y'all are here in Texas, and when you build these centers of excellence programs within a health plan, a lot of these folks don't want to travel, even with incentives. And that, I can tell you, and we went through with the school district, and they didn't listen to us. We kept trying to tell them we needed it. We have had several transplants already, so there's a lot of people. You got problems in those. So they generally want to stay local, is what we found. And because of our plans are so rich already, with really no barriers to care, unless we put a centers of excellence in, we just hadn't had to deal with that particular facility so far.
Are there any other questions? Well, I think we can wrap this up, David. That's okay with you?
Can I say one more thing, David? No, I just want to say one more thing where you guys sort of again, I want to be careful not to insult anyone's intelligence, so when I say this, but when you look at a health plan, this is how this works. So you physicians, if you've had to do a pre-cert, the way that goes down, and I'm going to give you an example of the school district, and this is a real story, and this is why healthcare is so crazy, and I think this is getting to what Dr. Mass said, that I never answered a question officially, which I'm going to answer now. I'm not real good at that. I speak the truth. I won't ever be a politician. When the call came, we had a $3.2 million heart transplant show up in our email in March of 20. It was an email from, and I can just public record, so I can say it. It's Cigna, fine folks there, and it was a $3.2 million heart transplant, and that's the first we heard of it. A heart transplant. We got no idea. In any of our other plans, that would have never happened. We're going to know. So we got the bill. It was $3.2 million, but because of that great discount, it was only $2.2 million. The problem was the stop loss. This is a self-funded group. The stop loss insurance was $900,000. So the school and the taxpayer, and I apologize. I meant to say I apologize for my passion. Was $900,000. So they lost $900,000. What could have happened in our model, in the care we're talking about, removing all these barriers, because Cigna didn't give a flip about that. Cigna's a processor, and all y'all calling them payers, they ain't no. The only payers are employees and employers. They're a processor of everyone else's money. And I did that talk with Rebecca over there with the Benjamin Rush Institute. You need to do a term reset. Get those terms out of your, you're giving them a lot of credit being a payer. So anyway, if that call had come into our deal, the call would have come into the pre-cert company, because we have to have a pre-cert company. They would have called me. They would have called our cost and quality navigation company. They would call the third-party administrator. They would have called our network development partner, and we would have been able to deal with that claim before it became a claim, and we would have had it for $184,000. That's number one. Number two, the kind of level of care I'm talking about, Dr. Mass heard this at our conference. We had a person that was in the middle of COVID last year, and she was a DeSoto Memorial employee, and her husband had some issues, and he needed to go to a long-term acute care center. If y'all ever heard of Kindred Healthcare, we have a direct contract with Kindred through our Fair Cost Health Plan. They liked what we did, and they saw us speak somewhere, and shockingly enough, we didn't upset them, and they wanted to work with us. So we were able to do that. So Kindred had a facility in St. Petersburg, Florida, which was about 45 minutes further than they wanted to drive. And we got them involved, and all this team I just described sat there and tried to help the member. But here's the most critical part. This member, their wife was such a powerful motivator for them, this husband, that it was important. We were able to get them on the first floor at a long-term acute care center where the wife could sit in the parking lot, because she couldn't get in the hospital because of COVID, and talk and look at her husband. I mean, that's the kind of stuff I'm talking about that doesn't exist in an insurer-built health plan, period. And that's what has to change. So then we worked a single case agreement because we didn't have them in our little custom network. And then they had to go to SNF. Y'all know what a SNF is? Good. I'm showing how smart I am again. It's good. Skilled nursing facility. I didn't know what it was either, Dr. Dewey, and they threw that stuff. I'm not sniffing. What are you talking about? So anyway, they were able to go there, work single case agreement. That's the care that I'm talking about. And Dr. Mass, if you speak up and support me, be nice. And she saw it, the love of this plan and the way they take care of the members. That doesn't exist. There's nobody at Abuka that was going to do any of that. They're going to stick them wherever they stick them. So anyway, I'm done.
Dr. Porter,
Sorry to get fired up.
Is there some closing comments?
I'm fired up too. It's good stuff, Carl. Well, a couple things with that, with the BUCA plans and the BUCA-driven clinics refusing care because it doesn't fit in an algorithm. People trying to find it. That's where a lot of employers are looking for opportunities. And the other one is actually, again, going back to the Medicare, people who are looking for different options. This is where policy initiatives can actually help things. Medicare plans, and I can't discuss A, B, C, and D very well, but all these various sorts of plans and it's well intended, must incorporate primary care in a variety of ways. And the primary care that's paid for that way through Medicare is very cumbersome. It's burdensome. If a Medicare patient comes into a Medicare accepting clinic, not mine, you have to bill them a certain amount. You can't waive it. You're actually required to do it. You have to make an honest effort to collect a bill. It's silly. Well, what if you peel off the primary care and just have a catastrophic plan? Then people can actually fund a DPC, not concierge, not boutique, nothing else like, but you can actually put that in there, and now you're dramatically losing costs because with DPCs, you're dropping the referrals in half. the drug costs drop, the amount of hospitalizations drop, because you're taking care of diabetes before it becomes CHF. So, yeah, I put some work for you, Andy.
Thank you.
I
Okay.
don't know if you guys have heard of Next Insurance, but it's a company that basically cares towards small businesses and figuring out what the needs are of that small business. So if I'm a plumber, my insurance for my plumbing business is going to be different from, if I'm running a little small, medical transportation company. So you understand what I mean? Why can't we derive health insurance plans that are custom made to the actual needs? So if I'm an elderly gentleman, I don't need OBGYN coverage. Is anyone thinking along those lines? Is, actually figuring out, like, if I'm young and healthy, I may want preventative care and catastrophic care, and I don't really need to pay for X, Y, and Z. That a lot of these plans, like, acupuncture, all this stuff that most people never use, but they're paying for. Is
Yeah,
there
in
anything
the-
like that? I'm just asking.
In the ACA plans, they want to bind everything and hear about, make certain there's OB coverage for people in their 70s. You hear about these odd things they're trying to cross-level risk and so forth, and all these the ACA plans cause so many problems, and David and Andy can talk about that eloquently for hours. But it's underlying. It's a lot of the opposition to these types of reforms is based on whether Washington or a state house think they're smart. It's benevolent hubris.
That's a great way to say it.
Keep working at it.
So there are opportunities or options like that. Cost sharing is one of them. Here in Texas, with the help of my friend back there, Charles Miller, we were able to get the Farm Bureau in the state of Texas be able to offer health benefits, but yet not be regulated as insurance. And what that does is the more that is done from state to state, if you have, and we did that with another organization, Texas Mutual. If they're not regulated as insurance by the state Department of Insurance, then they are not identified or seen as insurance at the federal level. If that's the case, then they don't have to abide by the ACA. And so they can offer the types of insurance products or coverage products that are specific to the needs of people at the local level. So yes, there are things that are like that, and we're working to do that on a larger scale. I think the other thing that we're working on in the next session is association health plans.
Hey, David, can I say one more thing? I want to thank all these physicians out here and thank y'all for all the work you do and taking care of people. I mean, I grew up with a dad that wasn't at every Christmas when he was in practice with one other partner until he expanded and had 5. I mean, he was there. He wasn't there at all the games, and so I know the price it pays. So I want to thank y'all personally for all the work y'all do.
I'd like to thank you for this opportunity to sit up here and moderate. Thank you, panel. I did just wanted to share one thing when they were talking about receiving a bag of tomatoes for medical services. And Dr. Mastova, you received collard greens as a med student, okay, in payment. My father, we lost my father at a young age, but he was an attorney, and he would he used his law degree in finance and would read wills, and people would call him for legal advice. And somebody paid him for his legal services. I don't know what it was, with a 1962 Ford Falcon. And it was about 10 years old, and he loved that car, and he drove that car. But we always loved it, yes. Yeah, exactly. You ate the collard greens. But anyway, David, thank you very much for this opportunity.
Thank you, gentlemen. Did they disappoint? Did you guys learn a lot? Thank you very much. And I just want it to be known, about 20 minutes ago, you told me you were done, and I came up here, and I just had to wait on you to finish. And they just they went on and on. Get off my stage. Notice I didn't say that to anybody else. I can with these guys. I wanted to tell a quick story, because we talked about Medicaid and Medicare. We did introduce a bill. I think it was House Bill 484, and it was to take dollars that would be allocated to the insurance companies, carve out the portion that would be the amount that would go to a direct primary care doctor, and it really would be the Medicaid beneficiary that would it would be their decision. If they wanted to go to a DPC doctor, they would opt into the program. That money would be provided to them on a card, and they would use that card to then interact and exchange with the direct primary care physician. We got shot down early on in the process. Number one, because of the extreme and intense opposition of the insurance companies, because they didn't want their piece of the pie, to dwindle. But then also, there was a signal from the administration that they would not offer a waiver for anything like that, because they didn't want to take away from the insurance companies providing the managed care. I also, under the last administration, sat down with the CMS administrator, Seema Verma, and I recommended the same thing with Medicare. I said, let's give these Medicare beneficiaries the ability to have a DPC doctor, a navigator, someone who could escort them through this complex system, because my wife's grandmother, I wrote a chapter in a book on DPC, and I start that chapter off by telling the story of when I was there for Thanksgiving, and she pulled out a drawer of 25 medications. And she would tell me the story of, I said, well, where are you getting all of these? She's like, well, this is from my primary care doctor, and this is from this fellow. And Susie at Water Aerobics told me about the cardiologist and how cute he is, and he is cute, and he gave me these. And she just went on and on. I said, does your internal medicine doctor know what you're taking? David, I don't think he does. Will you please bag all these things up? Do you have an appointment? Can you go take him all these medications and let him know that you're on these things? Because she just wasn't feeling well, and you can understand why. He got her down to 4. And she had more energy. She was able to go to more water aerobics, and just was feeling better overall. But that's what DPC can do. So that was my recommendation to them, and there was just this push and pull, and I just wasn't going to take no for an answer. In exasperation, the response from them was, where are we going to get the data? That was the response. Data was more important than affordable health care. So that's, and I'm glad that we had this discussion here. I'm glad we had the discussion earlier with Dr. Houston. We've got to figure out that piece of it too. Because when patients are able to make data portable, not necessarily how they spend their money portable and insurance and coverage portable, but the data itself, that's when we're going to be able to make more of an impact in these safety net products. So with that being said, gentlemen, thank you for your time, for your expertise, for finishing early. We're going to roll right into the next component of the conference. And this is real special to me. We're honoring another member of our coalition. Yesterday, we awarded the Physician Advocacy Award to Dr. Nikki Johnson. Today, we would like to honor a patient advocate. And early on in the development of free to care, I got to know the folks at AMAC, principally Andy and Bob. And even before that, I knew about Dan Weber, but I hadn't really met him yet. But I got to know part of his organization. And as we shared with them what the purpose and mission was of free to care, they went back to Mr. Weber, and he said, by all means, let's do it. And so they joined, and we really have never looked back, and we've grown and grown, and they've just, again, as I said before, have been an amazing partner as we've reached out to lawmakers. So for that, thank you. Mr. Weber is not with us, but we want to remember him, and we have made this Patient Advocacy Award in honor of his name. It's the Dan Weber Patient Advocacy Award. And I'd like to have Rebecca Weber, his daughter and CEO of AMAC, come up here and just talk a little bit about her dad and about AMAC, and thank you for being here.
Thank you, David. It's my pleasure. Yeah, thank you all so much. Very special for me to have this opportunity to talk a little bit about my father. He was such a great man, amazing husband, married to my mother for 55 years, grandfather, great-grandfather, a veteran,
He was also a visionary and an entrepreneur and loved America. He was a true American patriot. And he was a defender of our free enterprise system. He would say to me, Rebecca, we need to pay attention and we ought to be concerned because we don't want to see America become socialized medicine. He really believed that we had the greatest innovation, the greatest doctors, and the greatest care. And he really witnessed the government sort of overreach. You know, he said, the government has no place in the exam room. I can recall a time when I was at my doctor's and there was a procedure that the insurance company was denying. And my doctor at the time, very elderly, he's since deceased, but he was yelling on the phone at the insurance company saying, you don't tell me how to take care of my patient. And so all of this, that and also the other things that my father saw occurring across the nation really encouraged him to form what we know today as AMAC, the Association of Mature American Citizens. And we represent all Americans, especially those 50 and older. So you can imagine my father, how grateful he was when we had the opportunity to learn about the mission here at Free to Care Coalition. You know, we believe strongly in the same values. We want to see that doctor-patient relationship strengthened, and we understand that those three components of price transparency, access, and choice are absolutely essential in our private healthcare system. So I just wanted to say that you know, we feel very fortunate to be a part of this, and we look forward to explaining to our members. We are truly a member-driven organization. We have 2.4 million members in all 50 states, and you know, we've got a magazine. I encourage people to join for $16 a year. You're going to learn about the kinds of things that you're talking about here today, because we take this information, we create articles, we create information so that the American public can be, you know, better informed. This is not the kind of stuff that we hear about in mainstream news, certainly. So I just wanted to say, you know, to you, David, thank you so much for putting this on today. We are just flattered. We're honored. My father is looking down now, and he is so proud of what all of you are doing. So we're just so grateful for this recognition. Thank you all so much. Certainly.
Let me get this for you.
Oh, wow, look at that.
Give that to you. Thank you. Terry, come talk to us about our award winner.
That's
Our
beautiful.
award winner? Yes.
Yeah.
She's not here,
Yes. But you hold that.
but I will hold
Yes, that's for you. It's just so pretty.
it. It is.
Do you want to say a few words, Terry?
I will. I want to tell Darla's story because I think it's important, even though she can't be here today. And it was fitting to tell on the panel yesterday. I met Darla. She's now on our board at Patients Rising. But I met her because she was going through an issue with the copay accumulator from a really evil PBM, which is one of the things we were talking about yesterday. And she had called many of the national organizations that would look to support someone like her, MS Society, et cetera. And she didn't really get any help. And she found Patients Rising. She called us, and we didn't stop so we could figure out how to help her. And Darla is one of the people that you're talking about here today. Darla is a self-employed woman, lives alone. She has to buy an ACA plan because there's no other plans that are an option for her. She's not eligible for Medicare yet. She's, you know, a middle-aged woman. And so she was paying $700+ per month for her premium. She had a 70, whatever the maximum ACA deductible is at this point, was $7,200. So she had a $15,000 a year catastrophic plan that she wasn't using. The only thing that Darla had that was expensive was her medicine. And she got copay assistance for that, and then they took that away. And then the medicine she ended up getting for free. Sanofi ended up giving her the medicine for free, so she wasn't using the plan at all. And she ended up paying cash to her doctors because that was cheaper than using the plan, because she was never going to reach that deductible. And there's millions of patients like her in this country, Not all of them have MS or a chronic disease with the medicine that they need, but Darla is a healthy person except for these things. And the reason that she's getting this award, and David can attest to this, is Darla is a fierce advocate. She was born an advocate out of rage of what was happening to her. And that's what happens to many of us. You know, I was born an advocate. Well, I grew up in a household of advocates. My dad ran hospitals, et cetera, and I could go into that. But that comes out of that. And so one of the best ways that we can work together, sometimes I feel out of place in Free to Care because we represent patients and you all are doctors, and I'm not sure how to like exactly gel and how we can all fit in together. But one of the best ways is sharing your stories of these, inspiring stories of people like Darla, people that you're working with, patients who are enraged, who come to your system, who are helped, who come to direct primary care or these other opportunities, because that's how we can affect change, is real stories. Stories create change. So as my small plug, we have patientsrisingstories.org and a masterclass as well to train advocates, and it's one of the really strong ways that we can work with you. And we encourage the patients to share their stories and share their websites and their other organizations that they represent. They're not Patients Rising patients, they're patients who have stories. And like Darla, who now is a very good friend, and she's very sad she couldn't be here, but thank you very much on her behalf.
You want me to stand? Yeah. Thank you. Thank you so much. Thank you so much.
Well, this part right here is probably the worst part because it's the end. No, I know. Aw. Guys, this has been a real pleasure. It's been fun to hang out in person. It's fun to see my friends that I talk to almost on a daily basis that I don't get to see very much, and it's been a real pleasure. So thank you so much for being here. Let's let this be the spark of more momentum going into the remainder of this year and into the new year. We're looking at some tools to keep us connected a little bit better, maybe a little bit better than Twitter, but you'll be hearing from me on how we're going to be getting that done. So look forward to the prospect, remain hopeful. And I think that's the one thing that I want to share the most is when things are hard and there doesn't seem to be any hope, call some of your friends that you've met here today that are online, and we'll help you get it back, because there's something to be hopeful for. And with that, I will say goodbye and safe travels back to your home.